Good morning. I'll be speaking on penetrating keratoplasty. There are a lot of changes in keratoplasty in last 15 years, but penetrating keratoplasty is still there. Dr. Namrata will be speaking on lamellar keratoplasty. I'll be speaking on only penetrating keratoplasty. The technique, results and complication. This man, Edward Germ, in 7th December 1905, did first successful human full thickness graft. But three odd things happens on that time. The first patient was a bilateral lime burn, which is relatively contraindicated for full thickness graft. Then first donor was a live donor who had bilateral bad injuries but with good corneas. And third thing was done, the transplantation was done bilaterally on the same day, without any microscope, without any sutures. But that Golgar, he has survived with one eye, full clarity and returned to work. After 100 years, lot of advancements had happened with keratoplasty, with lot of suturing techniques, femtosecond lasers, corticosteroids. The success rate is highest among all transplanting procedure. And since 1961, we had done about more than 1 million surgery of keratoplasty all over the world. So PK has definite advantages like surgeon familiarity over 100 years, easy and conventional, less instrumentation, smooth learning curve, minimum primary graft failure, though the operating time is variable and overall success rate is between fair to excellent. If we see the statistics of India, last year we did 20,000 keratoplasty, and this nice table and chart has been made by Dr. Namrata. I am sharing with it that you will see that penetrating keratoplasty in the form of optical or therapeutic is around 70 to 75% of all keratoplasties. And if you see the commonest indication in our country is the keratitis, either active or healed, near about 50%. So I will be discussing both optical and therapeutic keratoplasty. Like both technically similar, but therapeutic PK is more challenging than optical. The outcomes are different in both the surgeries. The goals of surgery are different in both the surgeries. So also the complication. If you consider the period of evaluation, there is a chart of preoperative evaluation like our cataract cases. But in PK, we have to see other things like ultrasonic B scan is a must. If you have laser interferometry or potential acuity meter, you can get the potential acuity of that patient. Proper written consent for regular follow-up, that is most important for this patient. And the basic instrument, apart from your normal surgical instruments, you should have very good corneal scissors, trephines of different sizes, Teflon block, suture tying forceps, and we use the 10O monofilament nylon commonly. Pre-op preparation of the recipient, IV mannitol, usually 1 hour before surgery, moxie drops. Then pilocarpine if you are doing in a phakic patient, we try to constrict the pupil to minimize the damage to the lens capsule and also dilate if we combine with cataract surgery. And we have to have providine iodine antisepsis. And last point is very important because a lot of these patients take more than an hour surgery. So if the patient gets mannitol, the patient should go to toilet, otherwise there will be mess on table. We have seen a lot of cases like that. Anesthesia is normally peribulbar or retrobulbar plus facial. good digital massage or pinky, and general anesthesia is preferred, preferably the young and anxious patient, mentally retarded, and when the surgery is, prolonged surgery is anticipated, and in case of children. So when we consider the disc diameter, recipient versus donor disc diameter, normally the size depends upon the recipient corneal lesions, and it is between 7, 7.5, 7.58, 8, 8.5. Normally we do oversize by 0.5 millimeter, except in certain circumstances like keratoconus, aphakia, very large graft, etc. Then coming to the exposure of the globe. So wire speculum is preferable. Bridal suture, if you want to give, you can give superior and inferior both, so that the cornea should be at the center of your field. Flaring ring is preferable with low scleral rigidity, like children, high myopes, keratoconus, post-vit eyes, and aphax. Exact diameter you have to measure with a caliper. Then you have to mark the host cornea. And when you prepare the donor, normally, as we said, that it is 0.5 millimeter oversize. The ideal graft size is around 7.5. So 7.5 is the ideal, or 7.58. If we go beyond, there are a lot of complications. Like if we take 8.5 millimeter graft size, it is better for astigmatism, but may cause more post-operative secondary glaucoma, PAS, and vascularization, and more rejection. But if we, on the other hand, if we take smaller size like 6.5 millimeter graft, that will cause more astigmatism. Donor trephination, normally we do from endothelial side nowadays, because we prepare sclerocorneal button and it is placed on a Teflon block, and there are handheld trephine. Most of our surgeons use handheld trephine, or there is the endothelial punch system. So there are different kinds of trephines are available in the market. And endothelial punch, you have like a spring action. You center the cornea after putting it over the Teflon block and just push that button. Recipient marking is important for suturing. People are using Baron's vacuum trephine, which is better but more expensive, like $70 per trephine. Like this instrument is very good. You have a precise sharp cut, more perpendicular cut, and Indian, what we use, around $4 in the market. So $4 versus $70. Then anterior chamber entry, you can directly go through the trephine, but most of the surgeons prefer to go deeper level and then cut with a side port blades with a control entry into the anterior chamber, then viscoelastic injected immediately, and to push back the lens iris diaphragm back to create space in the anterior chamber. Then you have to cut with the corneal scissors. People are using right and left scissors. Somebody is using universal corneal scissors, and we are in that corneal scissor. We can use a curved fine corneal scissor, either with universal scissor, single scissor is required, or you can use the left and right hand scissor for easier cutting and removal. And the holding of the scissor is very important, that it should be perpendicular so that you have a vertical cut. And try to remove the tag of the posterior tissue if it remains. Then with the advancements of the surgery, the femtosecond PK is now popular in some of the part of the world, in our country also. It gives a valve sealing edge design, excellent wound integrity, smooth anterior and posterior surface, least astigmatism, and suture removal can be done earlier. So we have different types like top hat shape, which provides larger endothelial surface. Then we have mushroom shaped. So it is like making a wooden furniture. So you have to make the slots like that. So you have also zigzag shaped. Different. You can customize this shape so that your own integrity is much more better. Then you have iris management. So you have to do iris management of the iris with synecholysis. PI is not mandatory except in some of the cases. Then suturing of the donor button, usually with 10 ohm monofilament nylon, first 4 cardinal suture, which gives a rhomboid or kite shape. Then you have to go with other suture. First suture at 12, then next 6, then third at 3 o'clock, fourth at 9. And these markers, initially we marked with RK marker, are very useful. Then we can have different types of suture like interrupted suture, continuous suture, or combination of both. But most of the surgeons nowadays prefer interrupted suture because the astigmatism control is much better, and especially in India where the follow-up is a problem, interrupted suture you can remove it very easily and early. So this is the suture. You will see that we start with 4 sutures, then we give 8 suture and 16 extreme left, interrupted suture. Then you can have interrupted running, you have double running suture and single running suture. So you can play with the suture so that your idea is that astigmatism should be minimum. The final check to check the wound integrity. So we have handheld keratometer. We check it like that case I was not happy, so I checked with and replaced 2 sutures so that at the end of the surgery, when you see those mires over the corneal surface, you see that mires are more or less circular. The ideal shape that it should be more or less circular. Yeah. Then this is the full surgery. So you measure. This is a case of macular corneal dystrophy. So you measure it. Here I have not used the marker. This is the corneal donor corneal trephination, endothelial side up. This is handheld trephined, vertical cut. So you have a beautiful button. Next, it's trephination of the host cornea. You make the centering properly. Then with your hand you just go clockwise or anti-clockwise. So mark sometime it is better to mark with Trephin blue. Entry, then use viscoelastic, normally HPMC. So use corneal scissors. So you have to use both right and left hand. If you use the same on the left hand side, you just cover it. Then adequate viscoelastic. Now you have to put sutures. So 8 sutures, 16 sutures. So normally if it is 7.58, 16 sutures are sufficient to secure the donor button with the host cornea. Then you have to body each knot. And at the end of the surgery, we just give ear is replaced. Most of the ear is replaced, and you check the wound with sponge so that there should not be any wound leak at the end of the procedure, and give gentamicin dexamethasone. So, and if you do cataract surgery along with it, it is difficult in different scenarios. If you have a total dense corneal opacity, you have to go open sky technique, which is technically very difficult. It's very difficult to do a rexis from here. If it is a partially visible, so you could do SICS or phaco along with it before actually making the. Sometime it happens that during cutting of the donor host cornea, you feel that there is vitreous upthrust, and in that case you stop your procedure, give some interrupted suture, so that wait for some time and then again proceed for the same. So in different scenario we have to tackle this lens differently. Then coming to the therapeutic, there are a lot of indications are there. Most important is non-responsive corneal ulcer, large desmetocele impending perforation, large frank perforation, etc. So here more of freehand define you have to do most of the time. You could mark it, but sometimes the margins, it is very difficult for large ulcers. So I am showing two videos. You see that on the left hand side it is like that, and right hand side you see the ugly picture of corneal ulcer. Cornea is full of pus, so you have to remove the pus before doing the keratoplasty. So with the side port and with the Simcoe cannula you remove the pus. Here the main goal is to save the eyeball. So when we tell to the patient, optical is not the idea here. Here the aim of this is to debulk the infection and keep the eye, non-infected. Later on you can try some other things. So anterior chamber wash is very important here. We give, depending upon the etiology, like intracameral amphotericin B or intracameral like vancomycin in these cases sometimes. So first day check is visual acuity, slit lamp examination, suture status, wound leak, etc. Patient has to be followed up at a regular interval like 1 week, 1 month, 3 months, 6 months, then yearly. And have to follow up this patient lifelong. Steroids should be tapered gradually. And each VC check for 4 things like vision, tension, graft clarity and sutures. Explain about RSVP, that is redness, any sensitive abnormal sensation about any abnormal discharge, visual acuity and photophobia. And final spectacle usually given after 1 to 2 years when all sutures have been removed. RGP contact lens is the last management. Results, so far the results depends upon the indication. The best results happened with keratoconus, early Fuchs, stromal dystrophy, and worst is with ocular surface problem. There are good charts in the book, you can see all this. And outcome wise, there are certain prognostic factors where the surgery, you are doing good surgery but outcome is not good. Where the vascularization, one of the important prognostic marker. Then there are several studies which shows that there is a lot of debate is going on whether DALC, DISEC or PK. This is a debatable paper published in Ophthalmology Journal in 2014. Then keratoconus, PK, now people are doing DALC. PK for keratoconus is better visual acuity and survival than others. People have claimed that Australian registry, they have maintained a very good registry over the last 25 years. Graft in children are different, infants are different, their survival rates are not good. So long-term survival of infant, doing a PK in infant and children are not good compared to adult. So you have to take special follow-up care in this group of patient. Outcome of therapeutic keratoplasty is anatomical success. You see that 90% is anatomical success. And optical success, we do not assume, but some of them get very good optical outcome. Like this patient, one-eyed impending perforation. After 2 years, you see. Therapeutic people thinks that it is a very bad thing, don't do it. But if you do it right time with the right instrument and right medication, the optical, it gives a optical quality tissue. I can remember this is the daughter of minister from Bangladesh. I operated and evisceration was advised in the left eye, right eye is keratoconus you can see. And therapeutic PK done on emergency basis, and you see that result after 4 years, this girl is still having 6-12 vision. So with one graft, if you have very good tissue, sometimes you can give good. Sometimes you feel like God in these cases. So don't ignore therapeutic PK. And reinfection, though it happens, but if your initial case is very bad, so reinfection sometimes happens. It happens up to 15% of the cases. Now coming to the complications, you have intraoperative, early postoperative and late postoperative complication. Intraoperative, like it may be trephine related, uneven entry of the anterior chamber. You can damage the lens capsule or iris during trephination. And if you damage them, ECC mandatory, ECC with IOL maybe, but IOL power calculation is a problem. Then this is the dreadful complication, suprachoroidal hemorrhage. Its incidence is 1 in 500. There are several rate factors, but what is happening? So suprachoroidal hemorrhage is the most dreadful, and we have to, sometimes it happens and it is a bad day for you. And probably Namrata will show one live video of suprachoroidal hemorrhage. I have never get a chance to record any video in this. Then wound leak is important problem in early post-op, so shallow AC is very important. You check for wound leak, like Siddle test is very important. Then PED, persistent epithelial defect, is another most important complication in early post-op day. So you have to avoid the epitheliotoxic drops. So you have to know which drop have to be chosen for a PK cases. This is very vital. And usually it heals with lubricants, but sometimes you have to do tersorrhaphy. Then elevated IOP is very important. Urette-Javalia syndrome is unique entity where fixed dilated pupil, iris atrophy and secondary glaucoma. It commonly happens sometimes in PKP in keratoconus, cause still not known. Then excessive uveal reaction may happen in early, if you are manipulating iris more often, then it might happen. Then primary graft failure rarely happens nowadays with PK because we get good tissues, but it may happen with the dissect more often than PK nowadays. Then pupillary block, if you leave behind some of the air, it may go back and give pupillary block. Then anterior synechia, shallow AC, wound leak, again it can give rise to anterior synechia, so you have to release them. Then endophthalmitis and graft infection, this may happen in 1 in 200 to 1 in 500. CS rim culture doesn't prove, but if fungal growth is seen, you have to correlate with this, and sometimes it is helpful, but you have to explain this to your patient always. Like these are the cases, you see that it happens within few days of operation, and sometimes you need to eviscerate these cases. Secondary glaucoma in the late post-op period is the most important complication, and mostly due to steroids, topical steroids. So you have to, like, we give strong steroid, then we go to weaker steroid later on. So in the medical therapies, carbonic anhydrase inhibitor, it's better to avoid because we know that is not good for endothelium. And in some cases you need to do TRAB MMC, glaucoma drainage device, etc. And another important thing that in phakic, the steroid-induced cataract. So we see a lot of patients develop typical posterior subcapsular cataract in case of phakic eyes. So if you are patient going for steroid for a longer time, the initial award days it was saying that if the patient gets 740 drops of dexamethasone, he will likelihood of development of cataract. Graft rejection is most important, but with the advent of steroids, now it is less. There are different kind of graft rejection, but endothelial rejection is most important for us. The incidence varies between 10 to 17%, and most happens between 6 months to 2 years after surgery. And discontinuation of the steroids drop is the main cause in our country. And you will see a lot of patient suddenly comes with DV, with photophobia, and you can see typical signs of like Khoda dust line is one of the important signs of endothelial rejection. And urgent medical management is very important. You could revert back this if you give IVMP or oral prednisone or even say injection dexamethasone in these cases. And high risk cases you have to consider for cyclosporine, tacrolimus or azathioprine. Late complication, the high astigmatism is very important for us. That is why PK is getting less popular, especially with Fuchs dystrophy, where DSEK is giving excellent result. So you have to manage the astigmatism in this group of patients. Then suture-related problem, we tell our colleagues, don't ignore them. You have to immediately tackle this suture-related problem, loose suture, suture with vessels. Then you have suture-related infiltration and abscesses. We see a lot of patients in our country, and the patients are going good, but so that the suture removal at right time is very important in penetrating keratoplasty. Late wound dehiscence is also important. PK graft host junction never heals. So even after 7 years, 10 years, sudden fall, sudden strike with even a slap. I had a patient with slap by the husband, and the wife has got this kind of rupture of the wound dehiscence happen. And late graft infection is another problem. So if patients are going fine, after 3-4 years you will see that late graft infection is happening. And the recurrence of the disease is also important, especially important with corneal dystrophies. You have seen that one question was asked, that corneal dystrophy, especially with stromal, lattice, avellino or granular dystrophy and herpes simplex keratitis, it recurs very often. So it is not a very good indication for PK. And lastly, the late graft failure. So over a period of time, this patients will go, so after 10 years, 15 years, these grafts sometimes, after 20 years, these grafts fail. So late graft failure is a problem. So take home message is PK is still gold standard with lot of refinement in last 110 years. In majority of the cases, the results are good to excellent. The most common indication in India is keratitis or healed ulcer. Incidence of infective keratitis, you know, in India is 1.31 million ulcers per year. We have to do a lot of PKs, either optical or therapeutic. We have less corneal surgeon in India compared to corneal blindness. We need more corneal. You are budding ophthalmologists, so I expect some of you will join with us to reach our goal. We need 1,000 corneal surgeon at the rate of 100 keratoplasty per year to reach our goal. Thank you very much for your patience hearing.